Today we're going to talk a little bit about hip and knee diseases. So we're going to talk about the surgical approach to hip and knee disorders with our very well-trained guest speaker, Dr. Chet Simmons. Dr. Simmons is an orthopedic surgeon. He's a member of the Chester County Orthopaedic Group. A lot of people would be happy to know that he is a Bucknell graduate, because I know there are many Bucknell graduates here in Hershey's Mill. Attended Jefferson Medical College and did his residency in orthopedic surgery in the Rothman Institute, which is at Jefferson at the present time, and then went to the New England Baptist Hospital in Boston for a fellowship in total hip and knee replacement. So Chet, we thank you for taking the time to come and discuss this problem with us. I think we should start giving a little bit of a preliminary background and build up to the surgical approach to this, what leads to it and so forth. So could you tell us a little bit about what the main disorders are that affect the hips and knees?
Certainly. That's nice of you to have me today. What we are seeing in orthopedics today is really a big explosion in the incidence of osteoarthritis of the hip and knee, and that's the most common disorder that will affect these joints. Particularly with the baby boomers coming of age and all the activities that they were involved with in their youth, we're seeing a much higher prevalence of arthritis of those joints. There are many other conditions that can affect the hip and knee, but I think osteoarthritis is the most common.
And what are the prevalent symptoms that patients will experience with these primarily?
Well, most of us are familiar with those, but typically the first symptom that people complain of is pain, obviously. There is inflammation of the joint that causes swelling. That leads to stiffness and restriction of movement, and the patients notice difficulties with their activities of daily living, such as getting dressed, putting on their shoes and socks. A lot of patients in the later stages of the disease will develop night pain. They have achy discomfort at night that interferes with their sleep.
Is there anything peculiar, say, to the hip and the knee specifically?
I think with the hip, it can be subtle and it can be confusing. Many patients come to our office saying, I've got a back problem, or my legs aren't working, I have a knee problem, and it turns out to be the hip. The first thing that we often see is loss of rotation of the hip. People can't turn their leg or cross their leg to put on their shoes and socks, and they're not quite sure why that is, and it takes a little bit of examination to get to the bottom of that. With the knee, I think typically patients note swelling, stiffness. They may have mechanical grinding and popping, but the symptoms in both joints are kind of merge together at one point and lead to just pain and restriction of movement.
Now, is there anything that individuals do that aggravates this or makes it worse, or is there anything they can do to make it better?
Well, I think in some cases it is a genetic problem. There's a predisposition to arthritis, and it doesn't matter what you do, you're going to end up with it. We're seeing it particularly in the baby boomer generation. A lot of overuse injuries, people that injured their knee playing sports as a child, and over many years the joint begins to wear out. I think some of the excessive aerobic exercise and running that a lot of the people did in the 80s and 90s is catching up to us as well, and we may have gone overboard in that. So I think there's a genetic predisposition. There's also activities that put the joints at risk.
There's a lot of tennis players here at Hershey's Mill, and is this stopping and starting on a tennis court very hard on the knees?
I think it is.
Yeah.
Typically. I don't tell people to stop the activities that they enjoy, but using a little bit of common sense can be helpful.
Yeah. And is there anything they should do in particular to, like the shoes that they wear or something like that? Is there anything they can do to prevent this or make it better from a mechanical point of view?
Well, I'm not sure that the shoe wear has been shown to make much of a difference, unfortunately. I think in general we tell people to try and keep their weight down to an appropriate level. Every pound that you lose is 2.5 pounds of pressure off a joint when you're standing on one leg because of the magnification of the body. So losing weight can really help. I think maintaining flexibility When people start to have pain, they stop using the joint, and the joint becomes tighter and tighter, and it dysfunctions. So maintaining the range of motion, I think, is important. There are lots of supplements and dietary things out there, like the glucosamine, most of which do not have a lot of science behind them, and I'm not real high on recommending them to most patients.
This was leading into what I was going to ask you. What are the primary conservative measures for treatment that you start with?
Well, I should mention, since we're at Hershey's Mill, that the most popular thing I hear of from my Hershey's Mill patients, and some of the audience members may recognize this, are the gin-soaked raisins. I've been told by a number of Hershey's Mill patients that if you have 9 gin-soaked raisins every morning, that it will ward off the symptoms of arthritis. So I don't know of any scientific data behind that, but it's something to consider.
You soak them overnight? Is that
That's what I understand. Everyone has a jar of these on their kitchen counter here, from what I've been told.
Well, I haven't heard that one. That's very interesting. Is there any particular kind of gin that should be used?
No, I've been told they must be yellow raisins,
Yellow
not the
raisins.
brown raisins.
So the gin doesn't make any difference. Okay, that's pretty good. What about physical therapy? And this is commonly said to people who have joint pain that they should start physical therapy. Of course, the limitations of the pain may interfere, but could you address that a little bit?
I agree. I think there is a role for physical therapy, particularly in the patient that has developed stiffness and loss of motion. Some physical therapy treatments and exercise actually exacerbate the condition and make it worse. So people with arthritis can only tolerate so much exercise.
I've heard it said that swimming is a better form of physical therapy for arthritis in general.
Absolutely. I think that's the best therapy out there, any type of water exercise.
Yeah. Now, what about the use of anti-inflammatory drugs? This is something that is very popular and has its problems. So could you address that a little bit for us?
The anti-inflammatories like ibuprofen, naproxen, Aleve, Advil, they go on and on as far as the names. They all work about the same way, and they can be effective in limiting pain and swelling, but they do have significant side effects, particularly in older folks. We worry about ulceration of the stomach, kidney failure, so they have to be used in moderation.
Is there any one in particular that's better than, or safer or better than the other in your experience?
You know, I really don't think there are. There are many, many different drugs, and as you know as a physician, the more drugs there are to treat a problem, the less effective any of them are.
Especially with arthritis.
But you may be familiar with the special anti-inflammatories like Celebrex, which are designed for those people who have ulceration or acid reflux problems. But Celebrex really does not work any more effectively than ibuprofen or the generic brands.
When you're prescribing these for people, and let's assume that they can take them without any problem, what length of time would you say would be reasonable to determine whether or not they're effective or not?
I would think within a couple of weeks, patients should know the difference. And if they're not getting a good benefit from it within 2 weeks, then it's probably not worth continuing.
Okay. Now, I was going to ask you about the viscosupplementation, but we gather that. Could you just explain what they're trying to do with that so people understand why you feel there are certain questions about it?
Yeah. Well, this viscosupplementation is a lubricating medication that we use in the knee joint. It's injected into the knee much like a cortisone shot, but it's a slippery substance that helps to lubricate the joint and protect the remaining cartilage. It's actually a natural substance, hyaluronic acid, which is found in joints, and a way to synthesize this has been determined so we can get a purified form. And patients typically will get 3 injections about a week apart, and it can last for 6-8 months at a time, and then it can be repeated if it wears off. And it has very few, if any, side effects. I tell folks it does not cure the arthritis. It takes the pain from a 6 out of 10, typically down to a 3 out of 10. So it can be a very helpful adjunct in patients with early arthritis.
So it's really a delaying tactic.
It's a delaying tactic, but a worthwhile one because it's so safe.
Good, that's good. Now you mentioned too, and this is always a question about the injection of steroids directly into the joints. Could you address that, when it's indicated, what the contraindications would be, and what the possible adverse effects would be?
Right. And by steroids, we typically mean cortisone. That's what folks, the lay people, consider. Cortisone is really an anti-inflammatory medicine. It's like putting Motrin or Advil right into the joint. And it's best for an acute flare-up of arthritis. It's not a good long-term management strategy because with repeated injections of cortisone, it can actually damage the joint or hurt the cartilage. So we use them judiciously for patients who've had a flare-up.
Is there any real contraindication to the use of these?
It can affect the blood sugar in diabetics. As an endocrinologist, you would know that, so we're very careful about...
I asked you the question.
We're very careful not to upset people's blood sugars if we can.
Okay. The orthopedic surgeons are always my favorites when it comes to injections. Now, when these conservative measures fail, what's the usual next recommendation?
Well, with the hip, there aren't too many other simple solutions. Injection of the hip joint is difficult to do and not very effective. And we don't have a real minimally invasive surgery for the hip. And ultimately, patients that have severe pain elect to go ahead with a hip replacement surgery. With the knee, we can sometimes buy some time by doing an arthroscopy, a minimally invasive outpatient surgery or scope, where we can clean up debris, remove pieces of cartilage that are irritating the joint, and again, buy some time for patients.
In those arthroscopic procedures, do you have I guess, a length of time that you could judge one of these is going to last, or does that vary from person to person?
It really varies on the stage of the disease, and it's not appropriate for a severely arthritic knee. It just does not help. With the early stages, if there are mechanical symptoms like popping and catching, we can clean up the debris and it can buy some time.
Right. Now, I'm sure you're used to this question. Dr. Simmons, when will I know when I need a joint replaced?
Yeah, I get that question about 10 times a day in my office. And the first thing I tell people is that this is not cancer we're dealing with. I never twist anybody's arm to have a replacement of a joint. Most people know when they're not willing to put up with it anymore. They've had appropriate conservative treatment. They continue to have pain. They're unable to exercise. They can't make it through the market. They typically start to have that achy discomfort at night that wakes them up from their sleep. And then they realize, I don't want to live with this any longer.
Yeah, and these folks are generally really ready, aren't they, psychologically, to have this done? That's the big issue.
Yes, I like people to make that decision themselves and not push them into it.
That's good. What we're going to do is kind of end this session, which was a session to build you up and give you information as to just exactly what the background to arthritis is, what can be done for it, what can't be done for it, and what then can be done as what we call invasive procedures. We try to be as conservative as possible, but sometimes it fails. So the next session is going to be dedicated to joint replacement. And we'll talk a little bit about hip replacement and then knee replacement and some of the other newer things that are coming along. And we'll be happy to go into detail with these so you folks will understand what's available and what isn't available. So I'll ask you to stay tuned. We'll be back in a few minutes. So with Dr. Simmons again, and stay tuned for the next session.